So we have the two additional speakers, Dr. Ramesh Venkatesh and Jay Seth. Ramesh Venkatesh is the guest talk. He will be speaking on vision, vital insights on strategies and outcomes in real world NAMD management in India. The talk will be for 12 minutes and request that you should stick to the time very strictly.
Definitely, sir. I'll do that. Are we good to start?
Yeah,
Yeah,
please
can I
start.
So good afternoon, everyone, and thanks to AIS for giving me this opportunity. I'll be talking on the real-world the treatment of neovascular AMD with intravitreal aflibercept, and we have titled this presentation as Vision, where we are going to be talking about the vital insights on the strategies and outcomes in real-world neovascular management of AMD in India. And when you look at aflibercept has basically now become the gold standard or the first-line treatment in neovascular AMD. And when you look at these clinical trials which start comparing the newer anti-VEGF molecules such as brolucizumab and the faricizumab molecules, the gold standard or the comparative arm is always aflibercept 2 milligram. That is because it has become the gold standard treatment, and therefore you are now comparing it with aflibercept 2 milligram. But there is the real world data on the usage of aflibercept is very scarce, both from India and globally. And therefore, we wanted to do this study where our primary objective was to look at the real world outcomes of patients treated with intravitreal aflibercept in the management of neovascular AMD from a single center in South India. This was a retrospective study, single center of Narayan Nethralaya, where we included only neovascular AMD cases treated at least with one injection of aflibercept 2 milligrams with a minimum follow-up of at least 1 month post-treatment, and both including treatment-naive cases and previously treated or treatment-switch cases over a long period from January 2019 to December 2024. The exclusion cases were obviously cases with diagnosed or confirmed cases of PCV on ICGA, eyes where injection was advised but it was not taken, and cases where either they had no follow-up or follow-up less than 3 weeks duration. Now let's come to the results itself, and this was basically, you had 351 eyes of treated with intravitreal aflibercept for neovascular AMD, where 2 eyes had follow-up less than what was the recommended thing, and therefore we excluded them from the study. So eventually you had 349 eyes of 331 patients having treated with 1,254 injections of aflibercept 2 mg. The mean number of injections were around 3.7 with a range from 1 to 23. Now, out of these 1254 aflibercept injections, which was given over a 6-year period for neovascular AMD, 268 injections actually had follow-up visits less than 4 weeks, which were less than the recommended 4 weeks. And therefore, the analysis was only done for those 986 injections which had a follow-up of greater than 4 weeks between the 2 injections. In 181 aflibercept injections, the aflibercept was given following a treatment with a previous anti-VEGF injection. And if you look at this graph, it clearly tells us that the poor response was basically to ranibizumab, both the innovator molecule and the biosimilar molecules in almost 74% of the cases. Now let's look at the reason for switching in these 181 injections, and you would realize that no response to the previous injection was seen in 63 cases, 63 injections, and we also wanted to achieve a longer duration in around 30 cases. Now let's talk about the efficacy in these 986 aflibercept injections, and you would realize that over a period of more than 5 years, the CSFT reduction was maintained between the baseline and the last follow-up visit within the observation period. The CSFT reduced significantly over the first 3 months, and then it was maintained over the next 5 years. Even the visual acuity, if you look in terms of the ETDRS letters, was maintained in cases who had more than 5 years follow-up between the baseline and the last follow-up visit within the observation period. Now let's look at the fluid reduction which we had in the different compartments, and you would realize that over the follow-up status, the change in the fluid improvement was more so with the pigment epithelial detachment and the subretinal fluid, whereas the intraretinal fluid was almost the same in these follow-up patients. Now let me show some few cases. This is a 64-year-old male complaining of blurring of vision with a visual acuity of 6/15, had been diagnosed with both eye MACTEL but ended up with a left eye AMD CNVM, where you could see that there is a pigment epithelial detachment, there is a flat irregular PD, and then subretinal fluid as well. And this is what the patient was treated over the next 4 years, where in 2023, 2 years after the baseline visit, the patient presented with a massive submacular hemorrhage for which he underwent vitrectomy with subretinal TPA and intravitreal injections. And this is at the last follow-up visit a couple of years later, where he is maintaining with multiple aflibercept injections, a visual acuity of 6/18 at the last follow-up visit. Let me show you a case of peripapillary PCV. The reason for showing up this case was to show you the regression which we achieve with aflibercept for the polyps. So this is the pre-treatment FFA-ICG, which is actually showing the presence of the peripapillary polyps and the polyps which are present nasal to the fovea, infranasal to the fovea. And this is after the 3 injections of loading doses of intravitreal aflibercept, where the hard exudation has reduced significantly and the PED heights have reduced. And what you can see in the pre-treatment and the post-treatment FFA-ICG is the regression of the polyps which we achieved after the treatment. Now let's talk about the durability of the drug. And to assess the durability in a real-world scenario, we took cases with eyes greater than 2 years follow-up duration, treated only with aflibercept after it was initiated. We documented the visual acuity and the central subfield thickness at each visit, and also the fluid status in terms of PED, subretinal fluid, or intraretinal fluid at each visit. So we basically had 37 eyes who met this inclusion criteria with 637 visits. And if you look at the total follow-up duration which was available between the first and the last aflibercept injection, it was around 4 years. And if the median interval between the 2 injection visits was around 7 weeks, and the mean number of injections of aflibercept which was taken over this cohort of cases was around 9.2. Mean number was around 9.2 with a standard deviation of around 4.7. Now, what's interesting in this is that we looked at the percentage of cases where you could at least achieve a follow-up duration between the 2 injections of around 12 weeks and 16 weeks. And you would realize that almost 100% of the cases ended up with a follow-up interval of greater than 12 weeks and 95% or greater than 16 weeks, at least once in this observation period. Let me showcase another case of a neovascular AMD treated with the TREX regimen. It's a treatment naive neovascular AMD presenting in a 60-year-old female who complained of blurred vision since 1 month. She's a diabetic and a hypertensive, and a presenting visual acuity of 6/15 in the left eye. And what you could see is that there is a type 1 CNVM with subretinal fluid. And following this first injection itself, there was a resolution of the fluid. This patient was put on the loading dose with a 3 injection loading dose. And with this injection dates, we could achieve an extension of around 12 weeks between the 2 injections with the treat and extend regimen in this patient, with the visual acuity being maintained at 6/9 at the last follow-up visit. Let me showcase another case of a 68-year-old gentleman who is an ex-army person with a visual acuity of 6/9, presenting with a type 1 CNVM with subretinal fluid and a subretinal hyperreflective material with 3 loading injections. You could see that the subretinal hyperreflective material and the fluid has totally resolved. And this is over the treat and extend regimen, where you are looking at a complete resolution with a maximum treatment-free interval of at least 16 weeks between the 2 injections. When you looked at the safety, we did not encounter any case or any eye who developed a significant vision-threatening intraocular inflammation with intravitreal aflibercept. So let me just conclude and say that intravitreal aflibercept is the most preferred treatment drug in the management of neovascular AMD, even in the real-world settings. The aflibercept achieves a reduction in central macular thickness and subretinal fluid and pigment epithelial detachment resolution. The visual acuity did not change much following the treatment, which is expected with most of the NAMD cases. And the highlighting point is that we need a proactive and an aggressive treatment regimen, even in the real-world practice, to achieve the maintenance of the visual acuity and even improvement. Thank you very much.
Ramesh, for that enlightening talk. Before going on to the main instruction course, we have one more talk to complete as a compulsion. Thank you very much. And I now invite Dr. Jay Seth. His talk would be for 8 minutes.
Yeah. Thank you very much. So I will be presenting my talk on the ranibizumab biosimilar, that is Osiva, and how it has been changing our clinical practice. So biologics of anti-VEGF agents are gradually have revolutionized the management of multiple of these retinal vascular and degenerative disorders over the past more than 2 decades now. So treatment for all these patients require multiple injections. So that does improve the visual acuity outcomes, but at the same time, it increases the cumulative cost for these patients. So to optimize these health economics, biosimilars are a very attractive treatment strategies. So Osiva is one such ranibizumab biosimilar that has been regulatory approved for multiple indications, including the neovascular AMDs, macular edema secondary to diabetic retinopathy and RVOs, and also CNVM secondary to pathological myopia. And it does have a very important scope of reducing the treatment cost by almost 50% for all these patients. So this regulatory approval has been obtained based on the very extensively done phase 3 study where it was compared to Accentrix and it showed non-inferior visual acuity outcomes at the end of 16 weeks. So I'll be just sharing my data also, how we have evaluated it over a period of 5 months from September 2024 to January 2025 across various indications. So we looked at the changes in the visual acuity as well as the macular thickness for all these patients, as well as the changes in the IRF and the SRF in patients who had macular neovascularization. So coming to the results, we evaluated 82 eyes of 76 patients with a mean age of 57 years and slightly male preponderance that was there. So if we look across the indications that was there, most commonest was diabetic macular edema comprising 32 eyes, followed by RVOs, AMD or PCV, myopic CNVM, and there were a couple of cases of CACR also that were recalcitrant to other conservative managements. So coming to the outcomes in patients who had DME, within a matter of 4 weeks itself, we observed a significant improvement in the visual acuity outcomes. But at the same time, when we looked at the CMT changes, the CMT change, although it improved from 430 microns to almost 323, but it was not significant. But I feel 4 weeks would be a too short-term interval to actually look for these outcomes. But the visual acuity definitely improved. Whereas when we look at the RVO outcomes, although the visual acuity also improved significantly in all these eyes, but simultaneously there was an improvement in the central macular thickness also at the end of 4 weeks. And coming to the MNV patients, that is macular neovascularizations, so the visual acuity improved from approximately 20 by 180 to 20 by 120 in 4 weeks, although this was not significant. And at the same time, even the CMT started improving, but it was a very short period to look for the significant changes in that. So for all these patients, we also looked at the fluid data because that is what it actually matters, how the intraretinal and the subretinal fluid had changed. So in a matter of 4 weeks, almost 37.5% of the eyes had a complete resolution of the IRF, and almost 50% of the eyes had a complete resolution of the subretinal fluid also. Coming to the safety, there was one patient who had a marginal rise in the intraocular pressure that was managed with topical anti-glaucoma medications, and no incidents of intraocular inflammation were noted, or there was absence of any systemic adverse events also. So I would just end by discussing 2 very interesting cases that I managed with this Osiva injection. So first was a 48-year-old male who complained of left eye decrease of vision of almost 4 years. His visual acuity was 20/20 in the right eye and left eye was 20/80. So this is a fundus photograph, and I could see a presence of a CSCR kind of a picture in the left eye with a serous macular detachment. So when we did an autofluorescence, there was variegated hyper and hypoautofluorescence corresponding to the area of the CSCR. And on OCT, the right eye, it was normal, but the left eye showed presence of this large serous PED along with presence of subretinal fluid. There was another area of subretinal fluid with a hyporeflective double layer sign that was present just superinasal to the macular area. So when I did an angiography for the patient, it showed presence of an early leakage that corresponded to the superinasal CSCR and which started leaking in the mid phase and in the late phase. And at the same time, there was pooling that was noted inferotemporal to the macular area. And although there was a hyperfluorescence noted at in the foveal area, there was no specific leakage at that area. So I came to I did an OCT angiography also for the patient to look for any underlying CNVM network, but the superficial, the deep, and all the other plexus, there was complete absence of any neovascularization. So I came to a diagnosis of left eye CSCR and focal laser was done to the extrafoveal leak. So 1 month post laser, the CACR started resolving in the extrafoveal location. However, at the same time, the patient had worsening of the visual acuity to 20 by 100 from 20 by 80, and there was an increase in the amount of subretinal fluid that was there, and the PED height was almost similar. So at this stage, I gave the patient 1 dose of Osiva, and then after a month, the patient's visual acuity improved from 20 by 100 to 20 by 50, and there was a significant reduction in the subretinal fluid that was there, although the PED height was similar to that. A second dose of ranibizumab was given, and 1 month later, his visual acuity again improved to 20 by 40, with almost near total resolution of the subretinal fluid, and even the serous PED height started resolving in this patient. So there was a kind of a very good response with the injection, although there was no specific network that was noted on the OCT angiography. Now this is a second interesting case of a 65-year-old lady who presented with decreased vision in the left eye of 1.5 years duration. Her left eye BCVA was 20 by 80. Now this is a fundus photograph, and it showed presence of an abnormal MNV that was there at the posterior pole with a exudative kind of a picture surrounding it. So when I did an OCT, right eye was normal, but in the left eye there was this presence of this huge thumb-shaped pigment epithelial detachment with presence of subretinal hyperreflective material and a large amount of subretinal fluid in that area. And this is another configuration of the PED that was there in the superior location. So I did an OCT angiography for the patient, and it showed presence of these abnormal network that was there just below the level of the RPE. So I came with the working diagnosis of left eye polypoidal choroidal vasculopathy, and injection ranibizumab biosimilar was given to the patient. 1 month later, the visual acuity improved to 20 by 60, and there was a significant reduction in the amount of subretinal fluid that was there, although the PED height remained almost similar to that. 2 more doses, that is, I usually give 3 loading doses for all these patients, and 2 more doses were given. And although the PED height remained the same, but the SRF resolved significantly in this patient, and the visual acuity also improved to 20 by 40. So when I did an OCT angiography also for the patient, so this was a network that was present at baseline, and this was a network that was present after 3 loading doses. So it did cause a shrinkage in the macular neovascularization network also on OCTA. So just to summarize, the real-world data on the ranibizumab biosimilar for various chorioretinal pathologies is definitely encouraging, with very good response noted on multimodal imaging. And use of all these biosimilars has the potential to reduce the overall cost for these patients by almost 25 to 50%. And it does help us to expand the use of anti-VEGF therapy, and at the same time lowering the total cumulative cost for all these patients. Thank you very much for your patient hearing.
Talk. Now we are starting the proper instruction course on diabetic retinopathy. As all of you know, that diabetes itself is a global epidemic, and we should all be very capable of managing diabetic retinopathy. So in this course, we are touching from base to the advanced cases of diabetic retinopathy. And now I invite Dr. Kim. He will be tackling on the systemic parameters and their management. Dr. Kim.
Thank you, Dr. Ajit. We all know the problem of diabetes and diabetic retinopathy in our country. With 101 million diabetics, we have a huge problem. This was a study, Raji Raman led study, multicentric study that we did sometime back under Smart India label, where we found the prevalence of diabetic retinopathy across the country, done over 10 states, showed the prevalence was about 12.5% with the vision-threatening diabetic retinopathy at 4%. Why this? Because the numbers are huge for every one of us to be aware of what diabetic retinopathy means to as ophthalmologists and what do we do about it. So I'm just touching upon the systemic parameters and how it impacts diabetic retinopathy. We have the modifiable factors and non-modifiable factors. Modifiable like the sugar, blood pressure, cholesterol, obesity, and many other things. And we have enough data in the literature to show the impact or the effect of these parameters, such as the blood glucose, blood pressure, to show how important or what is the role that it plays in the development of diabetic retinopathy. So duration of diabetes, we are all aware of. The longer the diabetes is with the patient, the more the chances of developing diabetic retinopathy over a period of time, even if they have a good systemic control. Gender, again, the higher frequencies for proliferative diabetic retinopathy is present more in men than in women. It was shown that it increases with age. Of course, the DCCT, UKPDS, and all that have shown that intensive glycemic control, how it can reduce the HbA1c and thereby reducing the progression of diabetic retinopathy to the advanced stages. Chennai urban study had shown that every 2% elevation of HbA1c, the risk of diabetic retinopathy is increased by a factor of 1.71. This study done by Mohan's group some time back to study the relationship between the regularity of follow-up and risk complications in patients with type 2 diabetes who were followed up over a 9-year period. They showed that when patients were regularly followed up, they were associated with significantly lower glycemic burden and lower incidence of retinopathy and nephropathy. So what it means is, how much do we as ophthalmologists take care of the patient's the control of diabetes? Most often we would ignore that or do not pay attention to that part of it, except when the patient brings the blood sugar values and you say, oh, it's very high, you need to control. But do we monitor it? So we all know this data that even if there is 100% control of diabetes, there's still a 25% chance that the patient may develop any retinopathy. But the more important factor is that there will be a reduction in the progression to the advanced stages of diabetic retinopathy if they have a good control. Glitazones, the drugs, anti-diabetic drug, they are associated with an increased risk of diabetic macular edema in patients with type 2, especially in those undergoing insulin therapy. And then semaglutide, the drug which is now used for many people, especially they even use it for obesity reduction. The SUSTAIN 6 study had shown that there is a 76% higher risk of retinopathy-related complications in patients taking semaglutide as compared to placebo. Focus study, we are one of the centers. There are multiple centers, about 16 centers in India. It's a global study across happening. Just the focus studies, whole purpose is to understand. It's a 5-year follow-up of diabetic patients taking semaglutide and those on other drugs with controls to see if semaglutide is causing any progression of diabetic retinopathy to advanced stages. So this study is currently ongoing, but the current advice is to be using this drug in patients with pre-existing diabetic retinopathy. You have to monitor them very closely because there are signs, there are interim reports that keep saying that there is the effect of semaglutide is worsening diabetic retinopathy. But that the end results have to show that or confirm that. Hypertension, yes, we are all aware that hypertension does, the good control of hypertension, definitely the chance of diabetic retinopathy. I would not go into all these details. Lipids, yes, control of lipids is very important. Dr. Amod Gupta from PGI Chandigarh has clearly shown how oral atorvastatin therapy in patients with type 2 diabetes with dyslipidemia reduces the severity of hard exudates and subfoveal lipid migration in CSME. So many of us do start these patients, especially when they are coming with extensive subretinal exudates in the macula, subfoveal exudates. It is important that you can start these patients on statins. Diabetic nephropathy and diabetic retinopathy, the subjects with microalbuminuria were around 2 times as likely to have diabetic retinopathy as those who do not have microalbuminuria, and the risk is almost 6 times in the presence of macroalbuminuria. Pregnancy and diabetes, because of the high levels of estrogen, human placental lactogen, there is a rapid progression of retinopathy, and they are likely to develop retinopathy and have progression over a period of time. So in women who begin pregnancy with no retinopathy, the risk of developing any retinopathy is about 10%. So they should be counseled regarding the effect of pregnancy on the retinopathy. All pregnant women with established diabetes should be screened in the first trimester of their pregnancy, and severe non-proliferative diabetic retinopathy or worse should be treated with scatter laser photocoagulation and stabilized prior to conception, because otherwise they can worsen to PDR, and controlling that at that point of time would become difficult. Anemia, again, patients with anemia were 1.8 times more likely to develop diabetic retinopathy than individuals with no anemia. And anemia can also lead to falsely low HbA1c levels, which may result in the undertreatment of hyperglycemia, so which could cause progression of retinopathy. I wouldn't go into the pathology of that. I was also wanted to touch upon this diabetic retinopathy and cardiac function. Coronary artery bypass surgery is definitely the preferred strategy for patients who develop multivessel coronary artery disease. But the presence of retinopathy is seen as a strong independent risk factor for all-cause mortality after CAPG. That is, the 12-year overall survival rate was 40% for diabetics with retinopathy, while compared with those without any diabetic retinopathy was 88%. We did a study at Arvind, and we found when we followed those patients who were going for a CAPG, those who had any retinopathy prior, before they had the CAPG, they had a higher risk of advanced mortality, while compared to those who never had any baseline retinopathy before. So this is clearly a very easy test that they can get to do. The presence and severity of diabetic retinopathy may be considered as a predictor of adverse cardiac events after CAPG, and simple ophthalmic fundus evaluation will help to prognosticate in these patients. But in clinical practice, do patients monitor their metabolic status regularly? Do we insist as ophthalmologists, do we have any way of following up these patients whom we are treating for retinopathy, and how often the systemic status and the ocular status and response to treatment is correlated over time? We are very happy when we treat the patient with the injections or the lasers and the edema goes away, but do we correlate it every time on the importance of using or evaluating the systemic parameters? I think that's something as ophthalmologists we need to follow up on this. Thank you.
Tim, actually this is very, very important aspect in management of diabetic retinopathy, that most of the time we criticize others, other specialists, that they don't take care of the eye, the retinopathy part of it. But most of the systemic parameters also need to be taken care of, and he has nicely highlighted different parameters that need to be concentrated on. But I ask you, Kim, at what stage would you say that I will counsel this patient for systemic control, very strict control?
No, over a period of, first of all, we do not have a baseline systemic status. Very often, if you look at it, do we take the HbA1c when the patient comes? For every patient, even those who do not have any retinopathy, when they are presenting, we would say, oh, you don't have anything, go ahead and control, or talk to your diabetologist. So that is something, I think it is something that we have to follow on a regular basis.
That is what is required. Even if there is no diabetic retinopathy, get all the parameters he has mentioned, and you see if there is any derangement, try to control by sending the patient to that particular specialist. That is enough. After that, the patient will also be careful and he will control. Primary control is very, very effective. Of course, if they are deranged, secondary control is also effective, but primary control is much more effective.
That's right.
And I have another question regarding pregnancy. During pregnancy, if there is a center involving diabetic macular edema and injections are required, what would you advise?
I would probably do a laser if possible, micropulse or is there. That would be the first choice of treatment if possible. Otherwise, go for steroid.
Yeah, I think I agree.
Yeah.
So if DME is present in the early pregnancy, you can think of laser. Steroids can be given, though there are some evidence of early teratogenic changes in early pregnancy, but you can think of. But if it's in the late pregnancy, no need to treat.
Yes.
Because after delivery, it will automatically improve. So no need to be in a hurry to treat if it comes in the last trimester.
That is the key. See, initial pregnancy and late pregnancy is very, very important. Late pregnancy, you should differ actually. And most of the anti-VEGF agents are going to absorb systemically and they can affect the fetus. So we should differ that. Steroids and lasers are less harmful, so you can prefer. It is not definitive. Now I invite Dr. Ajay Arora. He will be speaking on lasers in diabetic retinopathy and diabetic macular edema. He has a Rangachari paper presentation, so we are promoting him here, and we wish him all the best for that.
Thank you, sir. Thank you, sir, for making me part of this wonderful IC. I'll be talking on lasers in diabetic retinopathy and DME management and recurrences. You know, this was what Mark Twain said, that reports of my death are greatly exaggerated. He had not died and he was declared dead. So lasers to most people after the anti-VEGFs, they considered that they should be relegated to almost to the dustbin. And most people, at least in the US, would prefer using intravitreal injections. But lasers are not dead, and they remain relevant, and I'll show you why they remain relevant. Plan of my discussion is to show you what is known about lasers, the DRS, ETDRS protocols, and what was learnt. What is the plan for focal laser for recurrences, use of subthreshold micropulse laser, and use of lasers beyond the equator for recurrent macular edema and for cases of recurrent vitreous hemorrhages. And what am I doing as a combination therapy? I present a few cases where I have not only done a subthreshold micropulse laser for the macula, but a subthreshold micropulse PRP with a continuous wave laser. So this was demonstrated clearly by, and this is past knowledge, that laser works. It causes 50% reduction in severe visual loss in eyes treated with PRP, and the DRS recommended prompt treatment in eyes with high-risk PDR. The ETDR showed us that focal photocoagulation decreased the risk of moderate visual loss in cases of macular edema, and early scatter laser photocoagulation can be considered in cases of severe NPDR, and aspirin probably has no role. This was the picture which I had taken of laser I had done in 2004 before we started giving intravitreal injections, and you can see that we have gone very close to the macula, done the laser, and the patient did respond well. Of course, they had scotoma. We never bothered about it, but we definitely made the macular edema flat. But they were nice. It was difficult to do, but it resulted in good response. This is how we used to treat diffuse diabetic macular edema, or as a modified ETDRS protocol, this is how we used to treat. And for the focal treatment, this is how we did. Well, how does laser work? It causes an endovascular thrombosis with a heat-induced vesicular contraction, which is the cause of how it works. And there are other mechanisms also proposed. That is how the laser works. When the DRCA.net studies came up, so whenever you have a central macular edema, so macular edema is then divided into a center involving diabetic macular edema and a non-center involving diabetic macular edema. All cases of center involving diabetic macular edema need to be treated with anti-VEGFs, while if you have a non-center involving diabetic macular edema, you could do laser. So it's very important for you to superimpose the grid on a patient who has a macular edema, and it is a central 1 millimeter subfield area, which is a center involving diabetic macular edema. All the areas beyond it become a non-center involving diabetic macular edema. So the central subfield is 1 millimeter, which is 500 microns from either side of the center of the foveal avascular zone. So what was recommended that don't go closer than 750 microns. This is a patient who had an extra foveal or an extra non-center involving diabetic macular edema, and you can see that after the good metabolic control with focal laser to this area, 9 months later the patient has responded extremely well. So these patients need not be repeatedly injected on and on and on. We could give a definitive treatment by doing focal laser for these patients. So this is a chart. It's you could where we how do we go? What is the differences between a grid photocoagulation, a direct grid, and a mild macular grid? And I'll show you some cases. So how do we retreat a macular edema in cases of laser? Whenever you have a persistent or a residual central involving diabetic macular edema after 3 months and a new residual central areal thickness, the focal treatment can be brought up to 300 microns of the foveal center. This is what is recommended in the studies. We don't do it because I personally would not like to go closer than 750 microns from the foveal center, because we know that over the period of time these laser burns may expand centrally and cause further visual loss. So those cases we use anti-VEGFs, and up to 750 microns the recurrences can be treated. Now this is a patient, 61 years old male diabetic, who has got a persistent diabetic macular edema. When we do a wide field angiography, we find that there are leaking areas in the periphery. So the cause of the macular edema, you don't have to keep injecting these patients. If we go ahead and laser them in this particular area, additional PRP laser with limited amount of intravitreal injections, and the patient responds well. So no treatment except augmentation of PRP in these cases would help us. So you need to look at the entire fundus, to a fluorescein angiography, wide field angiography, and see if there are any peripheral leaking area which are responsible for the diabetic macular edema. This is another patient who had been lasered, who we did augmentation. Now when we have a wide field angiography available, we find that large areas of capillary non-perfusion. So this patient presented with recurrent vitreous hemorrhages, and we found that if you laser these areas, they responded well. Another patient who was a 69-year-old diabetic who had to undergo cataract surgery. When we did an angiogram, we found that NV in the extreme periphery. We laser these areas in the right eye and the left eye. We found large area of capillary non-perfusion, and the patient again responded well. The cataract surgery was uneventful. The macular edema did not increase after the cataract surgery, and anti-VEGFs were subsequently not required. Now, coming to subthreshold micropulse laser, which is close to my heart, we know what micropulse technology basically is. I will not go into the details of what micropulse is. Basically, so these cases we have used in cases of diabetic macular edema. An example of this is an extrafoveal diabetic macular edema. We have also used it in center involving diabetic macular edema, and that helps us in reducing the number of injections. So this is how the patient was treated, and again, he responded well. You can see the pre and the post OCT after the micropulse laser. So this is an example. I have now got about 7 cases who after taking a due consent, who actually would have required a pan-retinal photocoagulation, patient who had NV, who had a diabetic macular edema, but were ready to undergo a subthreshold micropulse PRP. This patient has now had a follow-up of 10 years with me. I have had 3 sessions of micropulse laser over a period of these 10 years. Whenever the patient comes, we go ahead and do over the areas of NVE and the areas around it, we do a normal continuous wave laser. Rest of the areas of micropulse laser was done, and we have followed them over a period of time on Octa, both the superficial and deep capillary plexus, and also done the field charting. So this is how this patient's periphery looked like. These are the areas which are marked out. These are the areas which we have done micropulse laser, and the other areas, the normal continuous wave laser has been done. So what is the advantage of all this? This patient, this is the left eye. I have done field charting and plotted the field, and sequential field charting has been done over a period of last 5 years. We found that these patients have maintained their fields, both 120-2 as well as 24-2 fields. So the advantage is, despite not having done PRP, the fields have been maintained. A micropulse laser, these patients do not, the field is not deteriorating. So that is an advantage in these cases. So the take-home message is laser photocoagulation, which was relegated to the backyard with the advent of pharmacotherapy, is with a better understanding, is making a comeback. PRP has remained the effective treatment for PDA for over last 4 decades, and maybe subthreshold micropulse PRP may be the way forward. Larger studies are required. Wide field angiography has helped us in identifying NV and CNP areas. So these cases who have peripheral NV, and there were cases of recurrent vitreous hemorrhages. After the vitrectomy in these cases, when we do laser, these recurrences of hemorrhaging can be reduced or totally stopped, as I've just shown you in a few cases. So laser photocoagulation is, however, the best way to go forward for focal extramacular edema, and subthreshold micropulse laser may be an effective way of treating diabetic macular edema, at least in reducing the number of injections. Thank you.
Thank you, Ajay. Listening to you, it appears that everything can be treated with laser. Diabetic macular edema, don't think so, please.
No, not really.
No, I'm joking. Because, see, over years, almost now 30, 35 years, 40 years, we have the experience of having laser, and there is a spread. Over 5 years, these spots becomes 5 times, 10 times, which is like near macular center, comes into the macular center and compromises the central vision and becomes a big scotoma. This is the danger with laser. So please be aware of that. That's why Ajay pointed out, whether you have noticed or not, studies say 500 or 350 microns from the center of the macula, you should not do focal laser. But he extended to 750. Actually, we should be even far away from that, because we have seen 15 years, 20 years laser, which these spots which we are giving, very small spot is becoming larger spot. That is full threshold. Subthreshold, he's saying that no scarring and no scotoma. The fields are very convincing. That is very good possibility. But when you are seeing the angiography, the periphery is avascular. There is a neovascularization in the area where subthreshold laser is done. How do you explain that?
So whenever there is an area of NVE, I will treat that NVE, but I will not treat the area. So whenever we have, so many times we have PDR cases, we have 1 or 2 NVEs, and we find that on a fluorescent angiography, the rest of the area is beautifully perfused. But we still go ahead, because of the protocol, we go ahead and laser it. Why? I don't find any reason why we should be blasting a normal retina just because one particular study told us that we should be blasting that retina. It doesn't sound logical to me. So for those areas, in case they are theoretically producing the VEGF, I would treat it with a subthreshold micropulse laser and not damage those areas. That is my conviction.
You want to repeat the micropulse once
Yes,
or twice? Yeah. Okay, thank you, Ajay, and all the best for you for the Rangachari.
Thank you.
Now I invite Dr. Rajiv Raman. He will be on the other side of it. Injections, both anti-VEGF and steroids.
Thank you. It's been pleasure being part of this instruction course for last couple of years, and I'll be next few minutes talking about the role of anti-VEGFs and steroid in proliferative disease and diabetic macular edema. So let's start with diabetic macular edema. There are some guiding principles of treating center involving diabetic macular edema. So you divide it, as Dr. Ajay rightly said, as a center involving and center not involving. Glycemic control, control of BP, lipids, anemia definitely are very crucial to get optimal result. Anti-VEGFs are the first line treatment for center involving diabetic macular edema. You can switch anti-VEGFs, you can switch to laser, you can switch to steroids if you feel that on follow-up it is poorly responding. OCT and vision are the key tests to determine the choice of your initial treatment, and even the follow-up. You want to do these 2 tests on a regular basis. And in case there is a vitreomacular traction, and in select cases where it is a non-responding DME despite all your efforts, vitrectomy still has a role. So basically, if it is center involving, non-center involving, you look into whether it's a responder. Again, there is no magic number of 3, but you, after a couple of injection, even first injection, you don't see anything, no response, you can still switch. If it is poor responder, you may probably switch to another anti-VEGF or a steroid. So it's not only this, if it is an on-center involving, as Dr. Ajay told, laser has a role. Sometimes it can be a center involving and later converts to a non-center involving. Again, laser has got a role in these cases. However, there are many patient-related factors that also play a role. Patients who had a history of cerebrovascular event in last 3 months, you want to avoid anti-VEGFs, you can consider steroid or laser. As we had discussed in pregnancy, early pregnancy, you can think of laser and steroid. Late pregnancy, you want to wait for a spontaneous recovery. If you have a patient who has poor compliance, you can consider steroids or laser. And if a person has chronic kidney disease, you start still on anti-VEGF therapy. On follow-up, if you see the renal parameters are worsening, you want to withhold the anti-VEGF for 1 or 2 months and then see how the renal condition is. There are certain eye-related factors which also play a role in decision-making in DME. It's a vitrectomized eye. We have shown in a multicentric study that initially there is no need to be in urgency to treat these edema. Majority of time it can still go away by themselves. If it is in the late post-operative period, steroids may be preferable. It's not like anti-VEGF will not work. You will need more anti-VEGF injection because the vitreous sump is not there. In proliferative diabetic retinopathy with DME, anti-VEGFs become first choice. Definitely needs to be PRP has to be added, or you can do a little deferred PRP after some time. In pseudophakic eyes, you need to differentiate between pseudophakic and diabetic macular edema, and you can consider steroids in some cases where they have reached a plateau and there is a persistent intraretinal fluid or the vision is not improving. You can think of using steroids. There are certain disease-related factors. If you have a plaque of hard exudate, definitely need to control dyslipidemia. Intravitreal steroids have shown that it works a little better. Again, anti-VEGF, it's not like they won't get rid of exudates, but you'll need more injections. And definitely you need to have adjuvant lipid-lowering agents. We have some evidence that if it is poor vision, thicker retina, probably the newer anti-VEGFs may be much better. And if there is vitreoretinal surface abnormalities, whatever anti-VEGF you use, the response may not be as good as compared to those who don't have that. You may consider intravitreal steroids if there is some visible traction, and if there is definitely a VMT, vitrectomy is the only answer. We do have newer agents for treating diabetic macular edema. Efficacy-wise, they also are similar to all others. They reduce the central subfield thickness, improve vision. They are known to cause early resolution of edema. We have less non-responders. The more importantly, people talk about durability. You may have longer interval of injection-free period with minimum recurrences. Yes, the claim is that there will be less monitoring visit and less injection visit. Time will tell us really it holds true or not. Coming to proliferative diabetic retinopathy, I think Ajay has told very beautifully that DRS study has shown us it reduces the risk of severe vision loss PRP by nearly 50%. It's not only DRS, they followed them up even after 10 years, nearly 20 years follow-up, the same patients. Again, it showed that 42% had retained vision of 20/20. And we were keen to look at that what happens to our Indian population. So we studied patients who have PDR, who underwent laser, 10-year follow-up, more than 900 eyes across the country. And we also found the similar result. Only 1/3 of them need vitrectomy. That means still laser is the mainstay as far as treatment of PDR is concerned. What is the need for changing the treatment at this stage? People think of using anti-VEGF alone. One reason could be they think probably there is a better anatomical outcome. Field loss may be less adverse effect, less progression, maybe or may not more economical. Let's see what anti-VEGF treatment have been, whether it has been successful in achieving this. So Protocol S and Clarity trials were two good trials which looked into use of anti-VEGF in proliferative diabetic retinopathy. So as far as new vessels, it is nearly same. Clarity did show more regression of new vessels. These are all 5 years follow-up study. Functional outcomes were nearly similar, and that was something which was a bit surprising, but what they showed that even the field benefit, that field loss would be less, will not be seen with anti-VEGF because disease still progresses. There will be areas of non-perfusion which will develop, and they will cause a scotoma. Side effects, the vitreous hemorrhage rates were similar. However, with presence of macular edema, definitely anti-VEGF has got an edge. Exactly as I told, the progression of disease still happens. There is ischemia which continues to worsen in both, and definitely cost-wise, we are aware anti-VEGF may not be that cost-effective. Probably anti-VEGF may not replace the pan-retinal photocoagulation. However, it can be used, and biggest concern is the loss to follow-up. Only 60% of the protocol as patients came for follow-up, and they tried analyzing the patients who were lost to follow-up, and what they found, these patients had poorer vision, they had more TRD, they had more rubeosis, again emphasizing the fact that if you are thinking of treating a patient with anti-VEGF alone, I have a couple of patients whom I am treating, you need to be sure that they have a very good compliance. So to summarize, diabetic macular edema, anti-VEGF still is the first line drug for treating them. The steroids are effective in a select group of patients, and the newer pharmacotherapy is emerging, which is mainly looking at increasing the durability. As far as PDR is concerned, PRP still is the mainstay of treatment. The patient selection is crucial if you are considering using anti-VEGF as a monotherapy, and there is definitive role of intravitreal. I have not touched on that. There is a role of using intravitreal anti-VEGF before diabetic vitrectomies. Thank you very much. I'd like to invite all of you to the retina meeting, a POTS meeting.
Thank you. Thank you, Rajiv. I want only one question. That is, we see a lot of diffuse diabetic macular edemas which don't respond to all the medication, injections, laser, everything you told. What is your suggestion for this big group? Because it's very big. I see it's a clinically challenging situation. How do you tackle this?
Yeah, these are nearly about, if you look at those non-responders in DME, it's about 30 to 40%, which are sizable amount. You don't want to stop giving anti-VEGF, but definitely these are the ones you need to look at systemic factors. Definitely you'll find that there are a lot of derangements which are there. You need to control that. It's good idea if you label them as poor responders. I usually do an angiogram also on them, because we routinely follow up only with OCT when you are looking at that it is just a moderate NPDR with DME. You don't repeat, but when you label them that it's not responding, good idea to do an angiogram.
Yeah, it's simultaneous anti-VEGF oblique steroid therapy and systemic stringent control. I would say stringent control. You need to be on the patient to get it controlled.
The
That's
other
very,
thing
very
which
essential.
is very common now, because of many of these newer anti-diabetic agents, you have something called as the early worsening of diabetic retinopathy. Their HbA1cs would be, they become many times non-diabetic, and retinopathy will increase. Their diabetic macular edema will be very bad.
Yeah,
Because
especially
that is also known entity, so you need to be careful. If
And
suddenly
when- yeah.
he's reasonably well, and I see that retinopathy has increased, I check his thing, it may be a very tight control, I think. But there's nothing to worry about that.
you want to say something?
Just the semaglutide is one of that, where
Yeah,
they
tablets,
say one of the
yeah.
reason is that it suddenly brings down the sugar. So
Correct.
Yeah, thank you, Rajiv, very
It's
much.
also the
And
change from oral hypoglycemic to insulin. The moment it changes, retinopathy will worsen in type 2.
those cases, will you not plan a anti-VEGF for some injection therapy and then tell the diabetologist that you now switch?
Many a times they come to us after they visit a diabetologist, and we do see them.
I think close association is
Yeah.
very much required. I now invite Dr. Vishali. It's a little bit change of order, but we will certainly discuss the content of the instruction course. She will be tackling on diagnostic evaluation of diabetic retinopathy and diabetic macular edema. Dr. Dr. Vishali
Thank you.
Gupta.
Thank you, sir, for the very kind invite. So we have done lasers, we have done injections, we have done metabolic control. So now let's see how do we diagnose, you know. So the patient might come to you at very early stage, which is very early non-proliferative diabetic retinopathy. You have done your 90-day, 78, or whatever you do, and you see these changes. Honestly, no further imaging is required. As per the protocol, you can keep the patient under follow-up, but even if you decide 3-6 months follow-up, it's very important to endorse them to get their metabolic control, to get their lipids control, and more importantly, the nutritional anemia control, because nobody talks about that. The Indians do not have anemia related to erythropoietin, they have nutritional deficiency. So it's important to look at that iron and vitamin D as well. You may go on to somewhere more, you are seeing here more hard exudates, more this thing, and you feel that, well, it's mild to moderate diabetic, nothing to be done, like I said. But before you jump on to that conclusion, you have to be very clear that there is no macular edema. So how do you make sure of macular edema? For the comprehensive ophthalmologist who probably do not use steropsis, there are monoocular clues. Like you see some grayish things in the center, you see the hard exudates. The moment you see the hard exudates sitting in the form of the circinate rings, there is going to be retinal thickening, whether you have OCT or whether you have stereoptic visions or not, but you assume and you think that there is macular edema. If you are not sure, it's good to do OCT, and for a comprehensive, when you do OCT, you have to categorize it into two very simple categories. Look at the line scan through the fovea. So you have the macular edema, which is involving the center of the fovea, and fovea is elevated. Now, these are the kind of the patients who would require anti-VEGF injection. The second kind is the macular edema, which is not really involving the fovea, which is away from the fovea. Now, these are the kind of the patients where you might consider laser. But be mindful of the fact, looking at the OCT map, the thickness has to be more than 300 or 350 micron before you jump on to starting any kind of treatment. There have been a lot of discussion about the patterns that you see on OCT. We do not have a real strong evidence that you manage them, but in practice, all of us do look at the pattern. This is the mildest form, the sponge-like thickness. Many a times you might see cystoid macular edema, and to me that is important because cystoid macular edema, I will not push in the laser. I will try to bring down the thickness by anti-VEGF, steroids. That's a different topic, but I would like these cysts to go down before you actually think you want to do something more. Sometimes you may have a serous detachment like this sitting out there. Important to rule out proteinuria in such patients and the role of newer semiglutides, pioglitazones, because like Dr. Babu said that we have to do a stringent control. But many of these newer drugs which are doing stringent control are causing macular edema as well. So you have to be very mindful of the fact that before you start jumping your guns at whatever you want to inject, make sure what therapy patient is receiving. And the most important is the traction. If you see traction on the fovea, this is a tractional variety of macular edema where neither the injections nor the laser will work. So if we have to do something, it is mostly surgery. Surgery brings about the anatomical results, but the long-term meta-analysis have shown that the vision does not do remarkably well. So let's go on to the next. The next component was a non-center involving. So if at all you are planning laser, do a good fluorescein angiogram. identify the microaneurysms, which you have to, and Ajay has already told you all about that. Moving on to more severe form, you will see more soft exudates, which are nerve fiber layer infarcts caused by the occlusion of the peripapillary arterioles. You may see these loops and beading. Now, don't take these beads and loops lightly, because these are the areas where you would invariably see large areas of capillary non-perfusion sitting next to loops and beads. So if you have wide field or if you have fluorescein, please go ahead and do it. Even if you don't have, it gives you a good clue that there is a lot of ischemia happening which needs to be taken care of. ETDRS did find that ARMAs, hemorrhages, venous beading and loop, CNP, and widespread leak on fluorescein are actually the risk factor for development of PDR, not multiple cotton wool spots. So NPDR goes on to the more advanced form, and you see more and more of these lesions. Now, if you are seeing a retina like this, which is ischemic, be very careful of labeling it as NPDR, because 50% of them are going to bleed over a period of 1 year. So if you have seen this patient, missed some fine new vessels, ask the patient to come on follow-up after 6 months, patient might end up like this. So even if you're advising the patients, please tell them to report to you at the earliest onset of floaters, because floaters are one of the very important early signs of a vitreous bleed. Coming on to proliferative, which is straightforward. If the new vessels are on the disc, you see them as mishmash, fine capillary network, and never let this patient walk out of your clinic without treatment, because new vessels bleed straight away into the vitreous. There is no barrier, there is no hyaloid there. So find new naked vessels on the disc, you have to take care. Don't wait for the angiograms. It doesn't give any more information. At the end, you have to inject and follow it up with PRP. This is how the NVD will bleed, and you can see the blood trickling into the vitreous, whereas NVEs are kind of more, you have some time to buy for NVEs, but NVDs you have to treat straight away. As PDR progresses, you get more and more of fibrous tissue, prominent tissue. So this is very simple. You look at the clinical exam and you know there is tractional RD because it is concave. But the moment you see some amount of convexity, take it as a combined RD, because the indication of surgery would be different for tractional than for the combined RD. The tractional RD we treat only if it is involving or threatening the fovea, whereas the moment there is a convexity, even if you are not able to see a hole most of the time because it is hidden under the fibrous tissue, this is an indication for surgery. Contracting vitreous is going to put on the optic disc, causing traction, and this is what is classically called tabletop traction of diabetic macular, of diabetes. So I have already told that there will be a tractional component which is concave, and then there is convexity, which means there is a rhegmatogenous component. So in conclusion, before you jump on to injecting laser or anything, it's very important to characterize diabetic retinopathy, and that characterization is mostly based on clinical exam. Thank you very much once again.
Yeah, Vishal.
Thank you.
Can
I
I
want
make
to
a
ask one
comment?
question.
Can I make a comment, small comment?
Yeah, please, please.
So as Dr. Vishali pointed out, it's very important to take the history before starting any treatment. So I recently had a case in which the patient complained of sudden decrease of vision, and in both the eyes together. And when I saw the patient did an OCT, she had those cystoid macular edema. So I thought like it is part of the diabetic retinopathy, and so I injected at that. But the patient did not respond to that. And then we took the history, why there was such a sudden in both the eyes. So she gave that her diabetologist had switched her to a newer drug called sitagliptin.
Yeah, semaglutide.
Yeah, and then we just saw one or two reports were there that this drug also causes macular edema. You just stop the drug and the macular edema reduces. So I think another important thing is a drug history also we have to
That is
ask the
India's
patient.
answer to
Already we have
Ozempic.
discussed Sangeet. We have discussed
Okay,
that.
thanks.
Okay. See, you have given a lot of GPs are there. I mean, general ophthalmologists are there, and beautiful angiographs. And OCT angio, a little bit. She's also skeptical about OCT angio. OCT, beautiful OCTs. Can you suggest to them which cases they should go for it quickly, so that they can selectively
Go for OCT.
OCT and FFA? Quick.
If you are seeing NPDR, which you are very sure is very early, and the macula is appearing what my PGs call dull foveal reflex. I don't know what that means. Always do OCT to rule out macular edema. That is one thing. The second is you are seeing featureless kind of retina. The patient does not look very good. It's a kind of bit sick diabetic patient. The retina does not have the normal redness to it. And you are not sure it is NPDR or not because you are not finding the new vessels, but something looks off. Get an angiogram done. It may be ischemic retina, which is featureless. Thirdly, you have seen some INV or you are in doubt, but you are not seeing any new vessels in the back. Always get the angiogram done for some of these eyes. But if you are seeing the new vessels, you are seeing NVD, NVE, there is no need to do any angiogram.
So markedly asymmetrical DR
Asymmetrical,
also is another
yeah.
thing.
Asymmetrical DR, in addition to angio or OCT, I would suggest systemic workup, very important.
Carotids. Just
Especially
stand behind the
carotid,
patient and pass the
myopia,
carotids.
trauma, and sleep apnea.
One of the factors that I didn't mention is about the sleep apnea. That's another very important factor that you have to check with the patient whether he has a history of sleep apnea, because that can worsen the diabetic retinopathy.
Snoring. Yeah.
Yeah. Thank you, Vaishali.
Thank you, sir.
Thank you, Dr. Ajit Babu. So, coming back to the basics, Dr. Ajit Babu is going to talk
introduce
about the clinical presentation and classification of in patients of diabetic retinopathy.
So actually the sequence is a little bit altered, but we will not reduce any excitement of this thing. You want to ask something? No, right? So the excitement will not reduce, okay? Clinical presentation is nothing but you are sitting in your clinic, a diabetic patient came and he sat in front of you and he is now challenging you that whether I'm having diabetes or not, or what stage I am, which management I require, and where I will go to get that management. These questions you need to answer, okay? So let us quickly go on to these slides. Actually, Kim already shared. But initial stages of ETDRS, you know all these circles where to take the photographs for analysis, which Vishali was highlighting, both angio and fundus photography. This is the grading which I quickly say this, but features are more important. Here, if you see, there is mild non-proliferative. There is something called minimal non-proliferative also. If you are seeing 1 or 2 retinal hemorrhages, that is minimal non-proliferative. Mild non-proliferative, then moderate, severe, and there is something called very severe and proliferative. Again, 3, early proliferative, then severe proliferative, advanced proliferative. So if you see the mild non-proliferative diabetic retinopathy, what are the features you are likely to encounter? Either microaneurysms, retinal hemorrhages, hard exudates, cottonwool spots. As long as you are seeing only these, you can be sure that this is non-proliferative. Of course, with hard exudates, there can be a simultaneous diabetic macular edema, which you need to quantify and then decide. Retinal hemorrhage is very well defined in ETDRS, and this definition is very, very essential in quantifying the severe and very severe non-proliferative diabetic retinopathy. I will tell you why it is important. So this is two grades here, and this is mild non-proliferative. You can see the wide-angle pictures. Now, the another advantage is if you cannot see with indirect or direct ophthalmoscope, you can take some pictures, then do an analysis. That is very good for you. I would suggest that. So you can see the mild non-proliferative or diabetic retinopathy here. And this is a little bit more severe retinal hemorrhages. But if you can count, what I would suggest is any single quadrant, you count the retinal hemorrhages. If they are more than 20, you can say it is a severe retinal hemorrhages. That is one factor which we need to consider. The second Vaishali suggested is to concentrate on venous bleeding. This is again very important observation. If in two quadrants, it is very significant. IRMA is also important. Even if one quadrant, it is a significant factor. And hard exudates, this is mainly for the diabetic macular edema, whether it is clinically significant, center involving, non-center involving. Here I have shown you three pictures. You can see any difference, right? As an ophthalmologist, we can easily say that the first picture, no maculopathy. The second picture, early maculopathy, but center is not involved. Third picture, center is involving, and it is a severe form of diabetic maculopathy. You require this gross identification to refer the patient properly to a retina specialist. So now I told you that severe and very severe non-proliferative diabetic retinopathy. I already defined you intraretinal hemorrhages, but they should be more than 20 intraretinal hemorrhages in a quadrant. Venous bleeding at least in two quadrants. Moderate to severe IRMA at least in one quadrant. This is 4-to-1 rule in ETDRS. This, if two factors are there, then it is very severe. If any one factor, it is severe. Very simple classification of non-proliferative diabetic retinopathy. You need not remember, the last slide of mine is very complex ETDRS grading, which no one can master. So why it is important? Because very severe, you see, in 1 year, half of them are turning into proliferative diabetic retinopathy. So follow-up is very, very essential. You can make it a closer follow-ups. Every 3 months or 4 months, that can be done. And diabetic macular edema, again, there are 3-4 classifications for diabetic macular edema. This is mild, moderate, and severe, depending upon the center involvement. Then CSM is the standard classification, which we always tell you, but here what is important is retinal thickening or retinal edema. And these are the types of diabetic macular edema. When you are seeing diabetic macular edema, see which type is it involved. Is it focal or a cystoid? By OCT you can identify. Ischemic FA can identify. Diffuse diabetic macular edema more than disc diameter, 2 disc diameters area, then it is diffuse diabetic macular edema. A combined form or retraction maculopathy. You need to identify which type is very essential because it also determines this is ischemic maculopathy. And then OCT classification also you should know, because you are ordering OCT but you are not telling the patient what type and why it is useful. So you should be very clear about it. And this is the different classification. If you see combined everything, no diabetic retinopathy, mild non-proliferative, moderate, severe non-proliferative, very severe non-proliferative, early, high risk, and severe proliferative diabetic retinopathy. Proliferative diabetic retinopathy also 3 classifications you need to identify. Then early proliferative, any proliferation, even if it is mild, means it's already proliferative diabetic retinopathy. It requires either laser treatment or newer studies, anti-VEGF injections if patient is coming for regular follow-up. Okay, this is high risk. Means you can see the neovascularization of the disc, which is more than 1/3 of the disc area. So definitely it is high risk, means this can bleed at any time. So it should be recommended for panretinal photocoagulation as early as possible. And in laser, this is very stable laser proliferative diabetic retinopathy, very clear, and there is no neovascularization anywhere. But this picture, you are seeing there is a active neovascularization with lot of areas which are not covered by the laser. Means supplemental laser is required in this. Advanced PDR means there is some proliferation, traction, vitreous hemorrhage. All this will amount to advanced proliferative diabetic retinopathy. So this is the simple classification. However, this is the classification given by ETDRS. Need to understand. We need not stage like that. Don't worry. By clinic, you identifying non-proliferative, proliferative, different stage of non-proliferative and different stages of proliferative, you are done your job. So you have already listened to different talks. Utilize that with this clinical examination, you are done with management of diabetic retinopathy. Very rare cases where the patients are coming very late. In those cases, definitely surgical intervention is required. So, to enlighten that, I call upon Dr. Sangeet Mittal.
Thank you, Dr. Babu. One of the important reason why you should know the clinical features is because many a times we tend to label it as NPDR or a moderate or PDR. But you have to remember these are chronic patients who are going to be following up with you. And only if you understand if the patient is progressing from one stage to the other and at what rate, you can focus on those patients who are progressing rapidly so that you see them on a regular follow-up or more frequent follow-up than those who are remaining at mild for years together. So this is important that at baseline you document. Photo document is the best, but if you can document it clearly at what stage the patient is, it will go a long way in treating that patient over a period of time.
That is also very important. Means clinical features, anyhow, you are examining and you are keeping in mind, but next time when he comes, in between you must have seen hundreds of patients or even tens of patients. So that impression will get erased. So it's always keep one fundus photography. And that time you can do second one and keep side by side. You can tell whether progression hasn't happened or not. That will also make you wise in analysis and management of diabetic retinopathy. Yeah, Sangeet.
Yes.
it's
Thank you,
for
sir. Before I start, just all of us have listened to the classification of diabetic retinopathy as was given by ETDRS. Just one question to Dr. Ajit Babu, sir. Don't you think it is a time to reclassify now and add another stage called diabetic vitreoretinopathy when the vitreous starts involving and then the treatment definitely changes?
Yeah. This almost 13 years ago, this classification has been proposed, diabetic vitreoretinopathy. In addition to advanced proliferative retinopathy, diabetic vitreoretinopathy has been proposed, but somehow it has not taken up very well. This vitreoretinopathy is required for a surgical intervention. Probably the very few numbers of the highly talented VR surgeons. That's why. So it is now your turn to classify that, reclassify. Because we have kept that classification in our operation theater in LV Prasad.
Okay.
Yeah, if you want, I will share the photographs.
Thank you, sir. So I have been kept as the last of the speakers because I think everybody feels that vitrectomy is the last option when nothing else works. So let's see. Vitrectomy for diabetic retinopathy has been indicated for such a long time now, maybe 50 years. Even the first vitrectomy, which was performed by Dr. Robert McHammer, he did it on a diabetic vitrectomy. He did a diabetic vitrectomy for a non-clearing vitreous hemorrhage. And the DRVS study we came in 1980s, and it had a longer follow-up, like 4 years follow-up, which is crucial in such a long-standing disease because smaller follow-ups doesn't matter because diabetic retinopathy is a long-standing disease, and 4 years follow-up was there. And they said that early vitrectomy improved outcomes, particularly in patients with type 1 diabetes. But still, what they said was 15 to 20% of eyes, irrespective of undergoing surgery, surgical intervention, lost vision. So that was one thing that kept the surgeons in check to go for an early vitrectomy because 15 to 20% of eyes were losing vision. But there were few drawbacks in the diabetic retinopathy vitrectomy study. One thing was that there was no intraoperative laser which was being done on these eyes. That time was not possible because of the instruments were not available. And now because the instruments which were rudimentary at that time, which have improved a lot nowadays with improvement in technology, improvement in your machines. And what happens is like if we try to wait sometimes, this was one patient, I advised her to undergo vitrectomy at this stage, but she had a very severe PDR, and she went to another doctor. He did laser, but the patient still kept on progressing. She progressed to a fibrovascular and contractile epiretinal membranes that started to develop in her eye. I advised her that you need a vitrectomy. Nowadays, we have come up with a new thing that is called the angiofibrotic switch. So once that the ratio changes between the anti-VEGFs and the CTG-VF, there is a lot of scarring which happens, and sometimes it becomes difficult to control the membranes at that time. So, but still, she underwent injections at some other place, and the membranes kept on progressing. They grew, they contracted to give rise to tractional retinal detachment. And then the breaks developed and led to a combined retinal detachment. And then she came to me and asked me, "Doctor, now you can operate." Okay, I said, I will still do it, but the prognosis is not as good as if I would have done at the first stage. And but these membranes are definitely difficult to treat because these are not the membranes that are like the epiretinal membranes. You just peel them off. They are multiple at the levels of where the new vessels are. They are glued. They are nailed at that points, and you have to take care. If you pull the membrane, they are just going to bleed and cause breaks. So now we recently had a study, and my previous speakers have discussed on this in DRCR protocol S. And they compared laser with anti-VEGF injections, and all these patients were on strict monthly follow-up. But at 5 years of follow-up, see, I told you diabetes is not a short disease, it's a long-standing disease. 51% of these patients needed supplement laser even after completion of PRP. And they also needed an average of 5.4 injections were needed in addition to the PRP they had undergone. And even after that, 46% still developed vitreous hemorrhage, 12% developed tractional retinal detachment, 4% developed neovascular glaucoma, and around 30% needed vitrectomy in both the arms, whether it was laser or whether it was injections alone. So despite, and you see what this is a trial in which every patient was followed every month. And if you come to real world, so there are almost 25 to 50% miss their appointments due to either they get ill or they are non-compliant or there are some financial considerations or their age does not allow to move them every month. So real world is totally different from what is happening in trials. And 33% of eyes treated with anti-VEGF developed TRD as compared to 2%. However, this was one of the good things that they pointed out, that anti-VEGFs alone cause more TRDs as related to PRP alone. And these patients, I had advised them surgery for their TRD, but the patient had gone to somebody else, and then they had injected, and you see there is a crunch effect. There is a formation of retinal breaks leading on to combined retinal detachments. And in the picture on your right, there was a macular hole which developed after an intravitreal injection. So you have to take care of all these complications in these patients. So now, just coming to now the standard, what are the basic indications of vitrectomy for diabetic retinopathy? They are non-clearing vitreous hemorrhage, a macula-threatening tractional retinal detachment, a combined retinal detachment, a neovascular glaucoma, if it is present, a severe PDR, which is progressing despite all the treatments, the laser or anti-VEGFs that have been given, a subhyaloid hemorrhage or a diabetic macular edema in some cases. So for vitreous hemorrhage, what the standard is that a non-clearing vitreous hemorrhage, 6 weeks to 6 months, you have to do vitrectomy, and you can do it earlier if it is associated with an RD, with a neovascularization of iris, because you have to clear and do laser as early as possible. In patients of type 1 diabetes mellitus, which has already been proven, we have to do it faster. In patients of subhyaloid hemorrhage, because if you allow them to settle, keep settled, toxins they develop in the central area and cause permanent loss of vision. And in patients of glaucoma patients who develop glaucoma resulting from the blood. So these are some principles of vitrectomy, the steps. So you start by clearing the media opacities, all the vitreous is cleaned, and then you create a plane of dissection. I usually start at the disc. And then you remove all these membranes, then settle the retina, and do internal limiting membrane peeling in some of these cases, then do a laser and use a tamponade if required. So, and this definitely in long term gives you better results. So here the membranes are being peeled. So now the cutters that we have, very small size cutters, which can easily atraumatically lead to removal of these membranes. Even you don't need scissors, intravitreal scissors, or other fancy instruments to get rid of these membranes. So you see we have completed the vitrectomy now, and so these are some of these patients. This patient, I remember, nowadays nobody has time in this such fast-living world. The patient had to go abroad. He said, "Doctor," I told him to wait for some time. The vitreous hemorrhage will go off, but he said, "No, I want it right now. Everything should be cured." So these are examples of patients who underwent vitrectomy for subhyaloid hemorrhage, for vitreous hemorrhage, and they improved. And this was one patient who had progression despite having multiple lasers, multiple injections, and you see after one single vitrectomy, the patient is doing well. So coming to that is when do we treat the retinal detachment? Obviously, previous speakers also spoke on it, that TRD, which is threatening the macula, or when it is a combined retinal detachment, you have to go in and you have to operate. And in these cases, as Dr. Rajiv pointed out, we give an anti-VEGF preoperatively, and it is helpful. It reduces you see how the new vessels are angry before anti-VEGF, but they calm down after giving that anti-VEGF, and you can complete your vitrectomy after that. Same patient undergoing vitrectomy again, you see there is hardly any bleeding while we are doing vitrectomy because we have given an anti-VEGF beforehand. And this is post-operative. The patient improved the vision to 6/9 and remained so without the need of any further laser or anti-VEGFs later on. And we are now able to do all these membranes. Like even the retina surgeons also used to think these patients have no prognosis. They just won't benefit. But nowadays, with improved instrumentation, with improved techniques, we are now able to remove these membranes also, and the patients do benefit after this. And this membrane, I'm just removing with a 25 gauge needle. I am using it to delaminate the membrane, and I'm using it to cut through the vascular nails also. And you'd see just the techniques and the technology has improved, which has helped us and to take care of all these severe forms of diabetic retinopathy without causing any further trauma to the eye. And the primary aim is we should not let the patient reach this stage, but this is the post-operative, the patient has improved. And these are examples of some of these patients who definitely after surgery have benefited from the surgery. And now coming to the last part, that is the surgery for DME. We generally, what is said is recalcitrant diabetic macular edema. The tractional macular edema, the primary vitrectomy for non-tractional DME is very, very controversial subject. I'm not going to touch that. And in the subfoveal exudate. So just a quick look, this is a vitreomacular retraction. And you see, after surgery, when we remove the membranes, the picture calms down. So in this patient, whether you give hundreds of anti-VEGF injections, the patient is not going to benefit till the surgery is being done. This is a patient of epiretinal membrane, improves after vitrectomy and to 6/9. And this is a patient of subfoveal exudates. In this case, we did a primary vitrectomy for DME, and after the injections, after the surgery, the patient improved and kept improved. And this is a patient large amount of subretinal exudation. She had been receiving multiple injections of anti-VEGF, but she was not improving. In fact, the exudates were increasing, but by single vitrectomy, you see the exudates started going down and they reduced. And what is what is the funda of why do we do vitrectomy for diabetic macular edema? It removes all the tractional forces at the retinal surface, which in some cases may be subtle or hidden. It reduces the oxygen consumption of vitreous, reduces hypoxia at the retina, removes the vitreous collagen on the retina, and decreases the VEGF load. What is the role of ILM peeling? The removal of ILM ensures complete removal of posterior hyaloid. And this iatrogenic trauma causes a cascade of chemical events which leads to slowly improvement in diabetic macular edema after vitrectomy surgery. And ILM peeling also increases the release of epidermal growth factor receptor, which maintains homeostasis. Thus, the vitrectomy acts as an anti-VEGF. Now, coming to the last part, is vitrectomy cost effective? Yes, it is very cost effective. It reduces your long-term treatment, and early vitrectomy reduces incidence of TRD and recurrent DME. So the key takeaways in my talk would be that vitrectomy should no longer be a last resort. It should be seen as a long-term solution for diabetic retinopathy, and early and timely intervention may, using modern vitreoretinal surgical techniques, result in a favorable outcome. With modern instrumentation, the vitrectomy has become comparatively safer and easier, and it is cost effective as compared to recurrent costs involved in anti-VEGF and laser. I don't advise you to that the first time the patient comes to you, you go with the surgery. But if the patient is not responding to your treatments with laser, with anti-VEGF, with your medical treatment, just think of vitrectomy as an early option, not as a last resort. Thank you.
Yeah. Means early vitrectomy will have a better visual results. But I have two questions to you. One is the very striking picture I have seen is repeated anti-VEGF injections in PDR with early proliferation. Vascular and proliferative membranes were there, and repeated anti-VEGF injections are given.
Yeah.
And there is so much of fibrosis that has developed.
Yes, sir.
Really striking picture, actually. This has been emphasized in this study that if the patient is not readily available for you for follow-ups or lasers are not given, this is one complication that can happen.
So I think what the recent studies show that the angiofibrotic switch, the theory which has come.
Fractional RD can happen.
Once the scarring starts, nothing can control it.
Yeah, medical case, suddenly you're turning into surgical case. So that is one thing. The second is the amount of diabetic exudates in the macular area. With vitrectomy, it is clearing. I have also done good number of cases like that. But if you see one case you have showed, there are hemorrhages which are developing at 6 months visit. What is the vision for this patient?
So vision had improved, although it is not very good, but earlier it was like counting fingers only. It has now improved to, I think, 660 or 636 after the surgery. But she is now maintaining it at least.
Because if you see the macular center, there are hemorrhages like that. Because few cases, very interestingly, it will improve, but not all cases. And the plaque which forms, if it is thick and it is involving all the layers of retina, it's better not to do it.
Yeah, once the scarring process starts,
Yes.
nothing helps.
So take a good call about vitrectomy in that severe forms of diabetic macular edema. With this, I'm very thankful to all of you for attending this IC. And your presence really helps us. Any questions are there? We can. Yeah, please. Yeah, you want to address? Yeah. See, the thing is, I defined you two things. One is severe non-proliferative. Second is very severe non-proliferative. Severe non-proliferative, only 15% progress in 1 year. Very less. 90% do not progress to proliferative. Very severe, half of them progress to. Means these patients are at high risk. If they don't come in 1 year's time and if there is a delay, they will be proliferative and then there is a risk of bleeding and other complications. So those cases it has been recommended to do the laser if you are not sure about their regularity of follow-up. Okay? Yeah. These days, speed world, isn't, but 6 weeks minimum you should wait. They disappeared, yeah.
ILM peeling was done. During the surgery or during the surgery, there is a risk, but I have not seen in my hands. But there is a risk. But I
Yeah.
think the earlier what people used to do was they used to create a macular hole and remove the exudates through that and then close the macular hole. So I don't think.
No, it's a very valid point because if it is a full thickness or partial thickness, but at 1 or 2 spaces it is full thickness, and you are not careful enough, full thickness macular hole can happen. For that surgical intervention, you should go around the hole and then come to the center so that the least. And if you cannot remove the ILM completely, leave part of it. There is no harm done. Okay?
No, if the plaque is only going to be very thick, then only you have to worry about removing that. And only if it is thick and covering across all the layers, your OCT would help you to define that. In those cases, yes, it will form because already the RPE under that is already degenerated. So is it
In those
worth
cases,
doing it? You have to worry.
We have said don't intervene also.
Yeah.
That's what we said, because improvement is less likely. Only thing is, if there are partial exudates all over, if they disappear, the field will improve. The vision may not improve, field will improve, performance of the patient will improve. For that reason, you can. Okay?
Thank you, sir.
With this, we thank you very much, and I thank all the speakers. One group photo, group is not there. Photo.